15 years ago, and just really enjoyed the interactions, and pursued it in graduate school, and have been studying it for quite a long time now. So it was actually kind of difficult for me to you think, oh, an overview of autism spectrum disorders, you should be able to do that in your sleep, and I can, but it was having a difficult time trying to figure out what I wanted to put into this presentation. And I say presentation, but I also want to make it, I know the purpose of these meetings is not just to give information, but it's also to provide you all a chance to network and to provide you a chance to ask questions as well. So, we're a small group, so if you have questions, feel free to speak up, and we can make it more of a conversation. But I did put some slides together to kind of structure what we're going to be doing. So what are we going to be talking about? We're going to be talking about a few different things. I'll be just defining the autism spectrum disorders. I chose to put in here a review of history, of just essentially the history and change in diagnostic criteria. This year in particular, I know there's been a lot, if you look on the internet or are familiar with literature, there's been a lot of talk about DSM-5 and what does that mean and versus DSM-4. And so there's been a lot of talk about what do these changes in criteria mean. So I thought it'd be interesting to kind of go through where did we start and now where are we? And then describe the core related symptoms of autism spectrum disorder. So even though there's been a lot of changes, there's still been a core of behaviors and symptoms that have gone throughout. Talk about prevalence, etiology, and touch, like, at the very end, very, very, very briefly on intervention. So that's going to be followed next week with Ethan Long, who's the executive director. We'll be talking about making informed treatment decisions. So, why are we even talking about autism spectrum disorders? When I first became familiar with autism, the prevalence rate was, I looked this up last night, I think the prevalence rate was like 1 in, let me get this wrong, it was like 1 in 1,000 or 1 in 2,000, something, and then people were like, well, what is this autism? What are you interested in studying? And now we know that the prevalence is 1 in 68. So a lot more people, there's a lot more public awareness about it. So prevalence of autism is rising, and just as this increase of prevalence, there's an increase in information out there. And when there's an increase in information, there's also an increase in misinformation. So what I really want to do is focus on those things. Like, what do we know? What do we know? The research is telling us what's evidence-based, because I'm sure, how many of you are parents, caregivers? Yeah, okay. And so you know that if you Google autism and treatment, autism intervention, autism cure, millions and millions of hits. I had a slide on a previous presentation that showed the difference between, I think it was 2000 and then 2005, the difference you got in hits, and it was astronomical. So as a caregiver and a parent going through and trying to call out information is really, really difficult. You even see on our Rice Krispies box, there's information about autism now. It's everywhere. It's very pervasive. So we're talking about it because we want to give you an overview and to help become, just more informed about, what's the good information. There are a number of different terms that you'll hear used when you're talking about autism spectrum disorders. There's autism, there's autistic disorder, PDD, ASD, PDD-MS, pervasive developmental disorder, Asperger's disorder. And again, that's kind of changed over the years. Some of these terms refer to specific diagnoses that have been listed in the DSM. Some of them were just kind of colloquial terms that individuals started to use to describe a common set of features. And now what you hear is autism spectrum disorder, whereas 2 years ago, so now the diagnosis is autism spectrum disorder that you would get if you go for an assessment, whereas 2 years ago, autism spectrum disorder itself wasn't a diagnosis, it was kind of a descriptive category, and it wasn't even in the DSM. So things have changed over time. So you'll hear people use a lot of different terms, but they're all part of the same family. So what do we know in general about an ASD? So we know it's a lifelong developmental disorder. There's significant delays in multiple areas, including development of socialization, communication, and behavioral issues. It's typically apparent before the age of 3, and it's associated with inheritance in multiple areas of life. And what we know is it's likely neurobiological in nature. I'll get into that more later on when I talk more about etiology, but from all of the research we know that there is likely neurological etiology. The other thing is it's found in all races, ethnicities, socioeconomic groups, and geographical areas. So there really isn't any difference when you look across cultures and individuals. So it's everywhere. You know, I thought it'd be interesting to give y'all a little bit of historical perspective on things. Like how did it all start? You know, it's one of those things where some people think like, oh, it's a recent occurrence, it's a recent diagnosis. And actually, the first use of the term autism was by psychiatrist Eugene Bleuler in 1912. And he used it to describe some of the patients that he was working with in his own hospital setting. If you're doing any research, you're probably more likely to hear the name Leo Kanner. And he was in the 40s, described a group of children in his practice who exhibited a number of different things, including some severe language abnormalities, social isolation, unusual responses to the physical environment. And he described these individuals as being unable to relate to people and to their environment, and having unusual reactions to their environment. He says that they appeared to exhibit what he called an extreme autistic aloneness, and often appeared to shut out the environment. And he used the word autism from the Greek word autos, which meaning self, and he used it because he thought that described the fact that children seem to lack interest in others. So, Bleuler used it first in 1912, but when Kanner used it, it described a little bit more of what we kind of see today as autism spectrum disorders. So Kanner was one of the first ones to describe kind of what we see today. And as time went on, there were more and more individuals who were like, hey, you know what, I have some similar findings in my practice who are exhibiting some aloofness and difference to others. And so Kanner and Eisenberg published a list of criteria in 1956, and they called it early infantile autism. And the criteria included aloofness, indifference to others, and resistance to change of routine. And they specified at this point that it had to be present before 24 months. So they published this list of criteria, but it still isn't anything that was formally recognized as a diagnosis. They're saying we're seeing these individuals, and this is how we're categorizing them. But it still wasn't recognized as an actual diagnosis. But their term was early infantile autism. So about 25 years later, still it's not a recognized diagnosis. But another individual came along, Rutter, and he says, I'm going to revise these criteria that Kanner and Eisenberg came up with, and he started calling it childhood autism. And so he suggested defining these criteria a little bit differently, and he gave examples of behaviors from his own research and his clinical experiences, and based on Kanner's descriptions as well. And the criteria that he set forth included onset before 30 months of age, a pervasive lack of responsiveness to other people, growth deficits in language development when the speech was present. When speech was present, peculiar speech patterns, such as immediate and delayed echolalia, pronoun reversals, what else? Resistance to change, and what he called kind of peculiar interest and attachment to objects. And he specified too that this was outside, because this was back in the 70s, even 60s, 50s. I don't know if y'all are familiar with the term of refrigerator mother, where they were still kind of under the idea that some of this could be caused by the environment. And he was saying this has to, and that there was some things that could be associated with also a diagnosis of schizophrenia. So he was the first one to say this is also outside of, it's not a part of the environment, and it's not associated with any other psychological disorders, including schizophrenia. They're not exhibiting hallucinations and things of that nature. So that was, late 70s. The very first time autism was actually recognized as a diagnosis was in 1980, and that was in the DSM-3. And in DSM-3, there was this new category of disorders that was described called pervasive developmental disorders. And the pervasive developmental disorders included infantile autism. And in the very, very beginning of DSM-3, there were 6 mandatory diagnostic criteria. So to receive a diagnosis of infantile autism, you had to meet every single one of these behaviors, these criteria that they listed. And if you met 5, you did not qualify for the diagnosis. So it was very, very strict in terms of who would and wouldn't meet the diagnostic criteria and receive diagnosis of autism. Well, 7 years later, in 1987, they published. So maybe I should take a step back. If you're not familiar when I say DSM, what that is, it's a Diagnostic and Statistical Manual. It's published by the American Psychiatric Association. It's revised every 7 to 10 years, and it lists all of the different psychological disorders that are out there and defines criteria for how you would meet a diagnosis. And it is revised periodically, and it's revised based on the research that people are getting, and it's revised based on and it's also revised based on clinical experience. So in '87, the category was changed from infantile autism and is now called autistic disorder. It's still under that umbrella of pervasive developmental disorders. But what they did is they divided the criteria into 3 main categories, including impairment in reciprocal social interaction, impairment in verbal and nonverbal communication, and restrictive repertoire activities and interests. Getting a little bit closer to what we are familiar with now, they changed it so that you didn't have to meet these 6 behaviors to get a diagnosis. They defined 16 different behaviors under, through these different categories. And they said that you needed to exhibit 8 of them for a diagnosis, so it wasn't as restrictive as it had been previously. All right. So I mentioned the severity levels that were added in with the DSM-5. So what they essentially did is they broke it into a rating. I have the specifics on some later slides. If you're really interested, I can show those to you, but I don't want to get into too far into detail with that right now. Essentially, what's the main takeaway is that level 1, we call it requiring support. So this is somebody who, is probably doing pretty well, but might require. They might be able to live independently, but might need somebody to check and make sure they're paying their bills on time. Might need somebody to provide some additional assistance with things in the home, and just some ongoing support. Level 2 requiring substantial support, and then level 3 requiring very substantial support. And requiring very substantional support. When I think of requiring very substantial support, meaning in my head I'm thinking of this might be an individual who would be living in a residential facility and maybe one-on-one care a lot of the day, or somebody who just you wouldn't be living home for any long period of time. So I don't know if in the thinking of the work group that was doing the DSM-5, if this was their way of kind of saying, you know what, we weren't great before about differentiating between Asperger's, PDD-NOS, and autism. So what we'll do is we were already kind of categorizing them in 3 ways: autism, PDD-NOS, and Asperger's. I don't know if this was their way of kind of making that differentiation, but that's what they did. So a little bit of history about diagnosis and itself. Now I want to get just a little bit more into some of the core behaviors and the things that we typically, the things that we see with individuals who are on the autism spectrum. I mentioned before impairment in social interaction and communication. So if you just kind of think back, every one of those from Hannah's original description to the current DSM-5, the one thread, one of the main threads that goes through all of them is this deficit in social interaction. And that's oftentimes what people would call the core feature of autism spectrum disorders. It's what, when you do research that really differentiates them from individuals with other disabilities and other disorders. There's some research where they've shown that they've compared individuals with Down syndrome ADHD, also a number of different disorders, autism spectrum disorders, and that social interaction difficulty is where you really see the main differentiating point. So what does that look like? And it can look like it manifests itself in a number of different ways. It can be, the difficulty or impairment in use of multiple, we call nonverbal behaviors to regulate social interaction. So nonverbal behaviors include things like gestures, such as pointing or head nodding, or following a gaze, body postures, eye-to-eye gaze, facial expressions. All of those can fall within this nonverbal behaviors realm. And as an example, you can see here, like this top picture. This would be, you see these kids are oriented towards the teacher. They understand that they need to be looking, and this child is just, oriented away. So that would be an example of just one small example of that. Other things that fall into this category are difficulty understanding facial expressions. So that would be encompassing the impairment use of nonverbal behaviors. Other thing that is included in here is difficulty developing and maintaining and understanding relationships and friendships. So there might be a lack of age-appropriate peer relationships. And this is often, it's harder, when you're diagnosing children who are really young. It's difficult to assess this. So it's easier to see with older individuals. So for example, a child might not have a best friend, or they might think everybody's their best friend because they don't understand when someone is just being nice to be nice, or when it means they're their best friend. It may also be that they just don't have any interest in having a friend, or that they share information that's inappropriate. There was, and because they don't understand like what's appropriate to share, what's not appropriate to share. There was a time when I was doing a social skills group a long time ago, and we had an older girl who came in, and we knew she had her homecoming the week before, and she'd been working really hard on helping them with the float. And said, "Oh my gosh, how was homecoming? You were working so hard." She's like, "That was great, but I had a UTI." So, like, oh, okay. So just some instruction on those types of things, like when it is and it is appropriate to share information, and so just some of that understanding of how sharing information that others might not be comfortable with might make them feel, and that's all part of that. The other thing is they may not seek, to seek out others to share enjoyment, interests, or achievements. This can be like a lack of showing or pointing to objects. This isn't, so I've talked to some parents like, oh, well, they'll bring me things when they want them. That's not the same thing. It's not for requesting purposes. It's just like, hey, isn't this cool? Like it would be pointing out an airplane in the sky. They're not pointing to an airplane because they want it. They're pointing because they're like, hey, I see something cool and I want to share this experience with you. So that's where this is, like when I talk about spontaneous seeking to share enjoyment. I have a video clip, if I can get it to work. Let's see. Oh.
Baby, you did great. You did it all by yourself.
Okay, so let me set this up. This is actually my nephew, so you can hear my sister's thick accent. So this is, what I want you to watch is a couple things. Like he finishes the puzzle, and what does he do? He looks, he talks, he's like, I did it, and he's excited, and he's with invitations, he's telling her because he wants to share that. He's excited, and he wants to share that excitement with her. And so I mean, like seeking, to share enjoyment. Look what I did, isn't this cool?
Mommy, baby, you did great. You did it all by yourself. I'm gonna do it again.
So that's just like this is one example. And again, I will say that, like I said, there's a spectrum, and we do have children who are on the autism spectrum who will at times seek out to share enjoyment. But this is just one of the things that can be associated with the impairment in social interaction and communication. The other another thing that might be associated is what we call failure to show social or emotional reciprocity. So the individuals might have difficulty showing emotional reciprocity. So they might not be able to really socially engage in a back and forth manner, or say when say somebody falls down and hurts their leg, or sneezes, or is crying, going up and saying, "Are you okay? Can I help?" Understanding, what needs to be done in those situations. And I will say that, a lot of these things, so the sharing enjoyment, the emotional reciprocity, those are things that, we as clinicians and providers work on and teach. So just because somebody's showing a deficit in these areas doesn't mean that it's not able to be addressed. It doesn't mean that it can't be taught. So I want to put that out there too. There are some estimates that show that up to 40% of individuals with an ASD do not develop verbal speech. But as I said, then there's some that are, the vocabulary is much more advanced than mine. Another thing that, and this is actually what I did my whole thesis and my dissertation on, is looking at the initiations and responses. So initiation and responsivity with individuals with autism spectrum disorders. I did it looking at typical preschoolers and the kids who work with on the spectrum. And the thing that's interesting with a lot of these kind of social markers is that a lot of them are things that you see develop pretty early on within typical development, and then remain difficulties throughout the lifetime for some individuals with autism spectrum disorders. So things, like I said, like that kind of shared enjoyment, using eye contact as to communicate. I can be a Kristen and give her a look, and she might know what I'm thinking, and those things are more difficult. And there might be, if Kristen were, has some of these social deficits, I might look at her and she might not understand. I'm not sure what's happening. So those are things that you see individuals pick up on from an early age, but we have to teach. So just as an example of just how early some of these, like the response to eye contact, response to parents' voice, develop within typical development. I have an example of, this is a child. I think he's maybe 8 months in this picture. I can't remember. It's my friend's baby. And what I want you to look at is, as she's filling him, where his gaze is, what he does in response to his mom's voice, and when she praises him and is excited, what his reaction is. Oh, there we go. Mm-hmm. So what I like to show there is that the whole time that she is filming this video, he's staring at her, he's looking at her, he's looking to see what she's doing. He rolls over, he keeps his eyes on her, and then when she initiates with him, he smiles. So when you're a baby, that's pretty, your responses are limited, but he recognized it and responded. So these are things that we typically see develop very early, but then we also have to teach with the kids individuals we work with. For individuals that do develop spoken language, what you might see is, we call it stereotyped, repetitive, or idiosyncratic use of language, meaning that they may repeat back what you say, or say the same thing over and over again, or sometimes we'll speak with a really, their tone is very monotone, or some other kind of idiosyncratic way. I've actually been working for a couple months now on teaching a child to vary his tone of speech. That can be one of the things. And if your tone is always sounding angry, even though you're not angry, that can be off-putting to somebody, and then interfere with your ability to make peer relationships, have a job, and all those things. Difficulty initiating or sustaining conversation, so understanding what appropriate conversation topics might be, when's a good time to initiate a conversation, and then how to do that, and then how to end it appropriately. Not just walking away when somebody's not saying something because you're not interested. It would be just nodding and then let you explain yourself to resolve in those kinds of situations. Then also preoccupation with certain topics. So it might be that I can sustain a conversation, but only if it's on what I want to talk about, my preferred topic of interest. Volume regulation, and then very literal interpretations of language. I had a really good one. I gave an example the other day, and I can't remember what it was. So I think I might have said it. Try it. What did I say? I don't know. Really, examples like cut the lights on. I didn't say that, but I did. And like, well, I can't cut the lights on. I can turn the switch, but no, I didn't mean to cut the lights on. I meant to flip the switch. So very little interpretation. So we have to go sometimes again go through teaching that. We actually did. We're doing with some of our kids programs are using literal versus figurative meanings of things. When I say it's raining cats and dogs, there aren't cats and dogs in the sky. It just means that it's raining very hard. One of the restrictive behaviors, intrusive activities is again the other category that's kind of been gone throughout all of the different descriptions, and so individuals with ASD might have different ways of interacting with their environment. Specifically, they might engage in behaviors, interests, or activities in their restricted or repetitive nature. They might get really difficult when really upset when you interrupt what they're doing. If he's a child, I was playing with a child today who's doing his trains, and I tried to I'm gonna do some trains too, but because I wasn't playing the right way, he got very upset with me. So it might be a specific way of doing things. It might be driving a certain route home and having difficulty even, wait, you're supposed to turn left there. Well, wait a second, I have to go this way, or there's a detour. And so coming up with those types of things. Stereotype repetitive speech, you're again repeating the same thing over and over again. It's motor mannerisms too. I mean, you're all probably familiar with some of the more common ones. Is younger children might be something like hand clapping or walking on your toes or tapping objects. Those are the things we commonly see. And then also hyperactivity to sensory input or unusual sensory interest. So it might be becoming irritated with certain textures of clothing or being under or over responsive to temperatures. And this is actually with the DSM-5 was the first time they really added anything in there about sensitivity and any type of sensory issues. Prior to that, they hadn't been a part of the diagnostic criteria, but it was something that we all, as clinicians, saw quite often. In addition, to the core symptoms of ASD, there are several other associated characteristics. And by associated, I mean that they're not diagnostic in nature, but they are often co-occurring or seen in individuals with ASD. So, I think I mentioned earlier, intellectual disability can be an associated feature. And I think the research I read recently was that someone can estimate up to 46% of individuals can have an intellectual disability. But again, there's a lot of individuals who are cognitively way above their peers and where you expect them to be. And I don't know if you've run into this. It used to happen to me. When I was first getting into the field, much more than now. I would say, I worked with individuals with autism, and they would say, "Oh, like Rain Man." So what's their specific talent? Like, well, some individuals might have what we call splinter skills or an extraordinary talent, but that's not necessarily the characteristic, and it's not necessarily the norm either. Other social characteristics include behavioral difficulties such as tantrums, non-compliant self-injury, hyperactivity. I mentioned a little bit like atypical reactions to other sensory stimuli. And problems with sleep and restricted patterns of eating. That's within our setting. We work quite a bit with families on sleep issues and eating. We know that those are often co-occurring. Too much or too little fear, so not understanding when a situation is dangerous, or being overly upset by something in the environment. And you can also see some co-occurring mood and anxiety disorders. So that's kind of like the core symptoms, the behaviors. A little bit about prevalence. As you all are aware, it's in the news all the time about how the prevalence of autism spectrum disorders is increasing. The current prevalence rate is at 1 in 68. Like I said, when I started, it was much lower than that, or higher. It wasn't much lower, higher. It wasn't prevalent. The prevalence was lower. Thank you. That it's 4 to 5 times more likely in males than females, and this is just Dr. Easy from 2000 to 2010. 2000 it was estimated at 1 in 150, and now 1 in 68. So it's it increased quite a bit in that time period. But you might be wondering why. What is accounting for this increase? Well, there's a number of different reasons, or there's a number of different theories. Bottom line is we don't have a clear answer. But what research has been done, and what we've been able to kind of work through, is that it could be that there are just more cases and more individuals who have autism spectrum disorders. The second also is that there have been changes in diagnostic criteria, meaning that changes in diagnostic criteria and people are better able to diagnose. So as you saw when I walked through what DSM-3 in 1980, when you had to have these 6 behaviors to get diagnosis, and now there's like 12, 16 behaviors, and you only have to have 8 of them, and they're a little bit more broad. You can see how that changed. More people might be fitting that picture. And then there's an increased community awareness too. I did a paper when I was in grad school, and I looked at the number of articles published in popular periodicals like Time and Newsweek on autism. And I wish I had meant to bring it with me. Essentially, it looked like this. In the 90s, there were maybe 2 cover stories on autism, and there were maybe 3 other just kind of in the pages. Between 2000 and 2004, there were 15 cover stories and another 40 just about autism itself, and that number has continued to grow. So there is more public awareness. I mean, it's hard to go anywhere where you don't hear something about it. So with increasing awareness becomes a better understanding of the signs and better ability to identify it early. The other thing that people have talked about is what we call diagnostic shift. And this is a phenomenon that occurs when an individual previously met criteria for another disorder, but now we meet the criteria for ASD. So when there are some significant changes going on with diagnostic criteria in the mid-90s, mid to late 90s, or mid-90s, I have a graph that shows what they used to call as intellectual disability with unknown cause was way up here, and autism was down here. If you map it out with the years and put in markers for where the changes in diagnostic criteria were, they essentially, as the diagnosis for intellectual disability with unknown cause was down, the diagnosis for autism spectrum disorders was up. So it was almost like this group of people who before we weren't really sure what was going on, so we just gave them this blanket diagnosis. Now, like, oh wait, they fit into this category. So again, that's another theory we have. So I don't think any one of these is the reason. I think it's a combination of a number of different things that's contributed to the prevalence. We don't have any one answer. Causes, again, we don't have any one cause identified. But what we do have, and what we do know, is that it's thought to be the result of genetic, neurobiological, and environmental factors. For example, there's been studies that have shown that among identical twins, if one child has an ASD, then the other will be affected about 60 to 90% of the time. In non-identical twins, we know that if one child has ASD, then the other is affected about anywhere between 0 and 24% of the time. And then in non-twin siblings, if one child has an ASD, then the other will be affected about anywhere between 9 and 19% of the time. So we know that there's some genetic and neurobiological component going into it. There's been some research looking at environmental factors such as exposure to toxins or harmful things during pregnancy. So looking at the prenatal environment and that potentially having associated with higher risk. The other thing I did put on here, but there have been more studies published recently about it, is increased, a higher paternal age has also been shown to be linked to increases in diagnosis of autism spectrum disorder. We don't know why yet, but that's been another that's kind of been researched. And have this right here, this diagram. So these stars, and I could probably put more up now by the time I made this graphic. Every single one of these stars represent an area of the brain that's been implicated in some study as being related to the development of autism. So what we take as a whole is that what we think is that there are probably multiple pathways to its development. I don't know if we're ever going to find one thing, if this is it, but I think there's multiple pathways to development, which also helps explain the spectrum of disorder. So anyway, I don't know if we're going to find like this is the one thing. So because there's no one biological marker, diagnosis is made by looking at the presence or absence of certain behaviors. So when we do assessment, it's not, we can't do a blood test because there is no biological marker. What we do is we go in and we involve a number of individuals, and we all look at the behaviors that are present and make the diagnosis based on that. So is there a cure? Nope, there is currently no cure for autism spectrum disorders, but there are effective interventions for addressing the behaviors that are associated with autism spectrum disorders. And the good news is that what we're able to do is teach individuals to become as independent as possible and give them the skills to start to reach the levels of their developmental age peers. Dr. Long will talk next week more about specific interventions and how to be an informed consumer. But just as a caution, be really wary of treatments that claim to be a cure. There's a ton of them out there. I'm sure if y'all have done any Googling, you've seen there's a lot of information out there that purports to cure autism. I remember there was one that I came across at one point where you could pay an individual, depending on the severity of the issue you had, whether it was autism or some other diabetes. Though diabetes might have been lesser level, and then autism was a little higher. You could pay them, and then they would pray for you, and then they said that would cure. So there's all kinds of information out there, and just be wary about the things that claim to over-exaggerate their abilities. But treatments do exist to help individuals in the autism spectrum function very successfully. We're able to work to lots of individuals go on to carry on jobs and live independently, have families. So with the correct supports, there is a lot that can be done. So I gave, as part of our handouts, I gave you all a resource list. And this is a list that I put together, and of places that I know have reliable information. This is information that's been vetted, it's evidence-based, there's research support, and I trust everything that's coming from these. So for information just about ASD in general, like the American Society of Pediatrics, the Centers for Disease Control are good resources. And for educating yourself just on treatments, my favorite go-to site is this one. I think Ethan, I might be saying a little bit, or be talking about it next week, but is this Association for Science and Autism Treatment. It's ASATonline.org. The thing I like about ASAT is it goes through in every single treatment you can be thinking about for autism, and it goes through and it summarizes the research information for you. And this is a group of professionals who are whose primary mission is to disseminate evidence-based information for parents, because they know it's difficult and they know y'all don't have a lot of time. And so this is one place that summarizes everything for you and is it's kind of a clearinghouse for anything. And then you can make a decision if this is something you want to be looking at any further. This is a book that I find to be really helpful. Again, it's the research behind the research in it is very solid. This is an article in the National Autism Center. Produces standards report. Again, just kind of goes through all the different treatment options that are out there and summarizes the research. So that's the end of my talk. What kind of questions do I have?
Early on in your presentation, you mentioned that it's across countries, nationalities, or
Yep.
just across the board. A lot of people subscribe to the idea that vaccination. So, what is the prevalence in, say, third world countries where they don't necessarily get vaccinations?
So when they've been able to go in and do, like you said, when they've been able to go in and do research and say, okay, of this population, how many of these individuals who meet criteria for autism spectrum disorders, it's the same. The reported rates might be a little bit different because they don't have access to psychologists and healthcare who would do that diagnosing. But when they're able to go in and really look at the population and do some assessment, they do find that it is the same across.
So it seems like, I don't know, the reason this is kind of on the top of my mind is because I just heard a parent the other day saying vaccinations are bad. And so I know that pediatricians are trying to educate parents, that know, in fact, there's actually research supporting that. I guess, wouldn't it be beneficial to have that information out there that, look, we've looked at across the board in these countries.
I mean, the information is out there. I think it just depends on where you look.
Right.
And unfortunately, I think what happens is sometimes the information that's misinformation gets picked up more by media, or because it's more like, oh, this is causes an alert, or the information for just as an example for vaccines, there's a really strong group of people who still hold that. It's like, I think this is where this is all coming from. They're very vocal, and they've got websites, and so there is a lot of it. There are studies out there. There's information that does speak to that. And I have articles on my computer I'd be willing to share with you if that were something that you were interested in and needed some additional resources. That being said, there's potentially multiple pathways to its development. And it is possible that for 1 in 20,000 individuals diagnosed with an autism spectrum disorder, that after they had a vaccine, there may have been some type of they might have been carrying some kind of genetic marker. And so that's they're as a whole, no, that is not the belief that we think that the aerosol and the vaccines that people had talked about, the mercury, led to it. And I'd be happy to share any articles that I have with you.
And also, vaccinations are given usually around the time that. So
that's exactly. Yep. That's the other.
More noticeable.
Yeah. Exactly. Yeah. Other questions? Well, this is an opportunity for us to give you all information, but also an opportunity for people to meet each other. And I know it's difficult to find time to get out and meet others who might be going through similar things. So that's why we also want to try this opportunity for you all to kind of network and meet and greet. So feel free to stay and chat and do whatever you want. Thank you so much. And if anyone's interested in anything, I have my cards here, and feel free to grab one.
You guys can take a few minutes to just fill out the survey as well, and then I will share next week. It's making informed decisions about treatment. So looking at what are the various treatment options, making informed decisions. So families are welcome. You guys are welcome to come back, or there's other parts to the series that would be beneficial. All of those workshops are going to be held here, with the exception of the the part 2 is challenging behaviors. So these are all standalone units, except for challenging behaviors, which is part 2, the second part.
And Henry, I don't know if you have a question on the survey. If there are things that I didn't cover that you know what, I would have liked you to touch on this, let me know and put it in there. You don't have some questions. Like I said, it was hard to figure out like what I wanted to include. I've been studying it for a while, so.
I have a question.
Yeah.
I know you said there's different levels, like from severe to less
Mhm.
severe. How do you go about finding out if it's more severe? My daughter, she had some, but she doesn't have most of the severe.
Yeah, yeah.
So, I mean, Fluky is okay with the Fluky, but the injuries, they're both so much. And
Yeah.
we only see, like, portion.
Mhm.
And I don't really, that's not knowing, like,
Mhm.
whether it's severe or
Mhm.
severe or not. So,
Right.
like, any certain way you can.
So what I hear you saying is that you haven't had like a really thorough like psychological evaluation or neuropsychological evaluation. And those are the kinds of things where those are more lengthy appointments. We go in, they might do some cognitive assessments, some language assessments, and it might be a speech pathologist, a psychologist, and other individuals who are involved would be giving you their opinion